Bismillahir Rahmanir Rahim. I'm Dr. Mohamed Ibrahim, Assistant Professor of Obstetrics and Gynecology, Mansoura University. We will discuss the lecture of puberty. For definition, puberty is defined as period of life during which sexual maturation is completed. We have maturation of sex organs, development of secondary sex characters, and reproductive capacity is attained. Another important definition is the adolescence, which is the physiological, social, behavioral, and personal independence leading to development of adult identity. That is the period where the child is changed into adult by these changes. Age of puberty between 9 to 16 years. For the duration, once initiated, it proceeds over 4 to 5 years from the start of the event till the end of the process of puberty. This diagram shows the maturation of the secondary sex characters, including mature breasts, broader hips, and the appearance of pubic hair. What about physiology of puberty, or what's called pubertal changes? Of course, we have hormonal changes from the childhood passing into the puberty phase. There is release of the hypothalamus from effect of higher cortical inhibitory impulses, which are present before puberty. These impulses will prohibit the hypothalamic pituitary ovarian axis, which is released from such inhibition and they become mature, resulting in release of gonadotropin releasing hormone, which acts on the pituitary to increase the release or produce the release of FSH and LH, which by turn acts on the ovaries to become functioning and producing steroid hormone release, increasing the release of growth hormone TSH and adrenocorticotropic hormone from the anterior pituitary, which will increase muscular and skeletal growth, which is the base of growth spurt. For the physical changes, we have the third thelar arc, which means breast development, which is the first visible sign of puberty in girls that occurs due to ovarian estrogen production. Starts by the age of 9 to 11 years and completes in 3 years. Present in 5 stages, which is called Tanner staging. The second is the adrenarche. Adrenal gland maturation with production of androgens, which will result in 2 events. The pubarche, which is the appearance of pubic hair, which may be the first sign of puberty in only 20% of girls and precedes the development of the breast, and it also passes into 5 stages, which is called Tanner staging of pubic hair. And the second event is the axillary. Axillary hair development passes into 3 stages according to the Tanner stage. So, adrenarche with the production of the androgens from the suprarenal gland will result in appearance of sexual hair in the pubic area and axillary area. The third event is growth spurt, which is called accelerated growth. Occurs due to increased secretion of growth hormone. Usually starts by the age of 9 and ends by the age of 40.5. It passes into 3 phases. Minimum growth velocity with a rate of 5 centimeters per year, and then we have the peak velocity up to 8 centimeters per year, and this is then declines within the stage of decreased velocity. Finally, we have menarche, which is the first menstrual flow. Menarche is usually affected by socioeconomic status, environmental factors, racial and geographic factors, medical endocrinal diseases that accelerates pubertal development like obesity, diabetes mellitus, epilepsy, blindness, and deafness. So the age is different in different communities and different population. In Egypt, the range of age of menarche between 10 to 16 years with mean of 12.5 years. We have development of genital organs and appearance of other secondary sex characters, which include high-pitched voice, feminine distribution of subcutaneous fat in the breasts, buttocks, thighs, and waist, and pelvis enlarges, widens, and take the gynecoid shape. So we have the hormonal changes, physical changes, and eventually we have psychological changes. The girl develop shyness, become secretive, and refuse her parent control, which is actually an important problem and should be managed with care. Tendency to other sex, which is called sex urge. The girl starts to find the difference between her and the other sex. Trying to explain pubertal initiation, we have many theories. First, the gonadostate theory, which include that hypothalamic sensitivity for the negative feedback to small amounts of sex steroids secreted by the ovary of the child is very high, and so such small amounts is quite sufficient to suppress the hypothalamus. With age, this sensitivity declines, and this results in the release of gonadotropin-releasing hormone. Second, the critical weight and body fat mass, which try to explain the initiation of puberty based on the amount of fat and the weight of the body. These are associated with metabolic changes leading to decreased sensitivity of the negative feedback loop. At 30 kilograms, there will be growth spurt with the release of growth hormone. 39 kilograms, we have peak height velocity, like we mentioned, up to 8.5 centimeters per year, and by the weight of 47.5 kilograms, menarche will occur. Another theories include onset of adrenal activity, which claim that the initiation of puberty is related to release of adrenal androgen with reduction of sensitivity to the negative feedback loop. Sleep mechanism, where changes in the neurotransmitters during the sleep cycle may play a role in the releasing axis from inhibition. The first event of puberty is thought to be nocturnal release of gonadotropin-releasing hormone during sleep. And sometimes the explanation is related to CNS maturation. Like we mentioned, we have the ternary staging for different events in the puberty. We have 5 stages for the thelarch, 5 stages for the puparch, and only 3 stages for the axillarch. Thelarch passes into first stage, which is the prepubertal, with the elevation of papilla only at the site of the breast. Stage 2, there will be breast pod. Stage 3, breast elevation. 4, areolar mound, and finally the adult breast contour. While the puberty, we have the prepubertal stage with no hair, then presexual hair, scanty and thin hair, sexual hair but sparse for stage 3, sexual hair limited to the monus, and then sexual hair cover the monus with transverse upper border, differentiating it from the male type with the triangle with the apex toward the umbilicus and spreading to the labia majora, medial aspects of the upper thigh. For the axillarch, which means the appearance of axillary hair, we have the prepubertal with no hair, then stage 2 with hair scanty, and finally the adult form. Now we go to abnormal puberty. We have 2 types of abnormality, the precocious puberty and the delayed puberty. Starting with the precocious puberty, which was defined as pubertal changes before the age of 9 years. Actually, the etiology is divided into 2 types according to the appearance of secondary sex character. The isosexual precocious puberty, where the female sex characters appears early, which is either complete or pubertal events occur precociously. This is related to the central cause, GnRH dependent, and this is the true one, with release of the gonadotropin releasing hormone from the hypothalamus, and this may occur as a result of idiopathic or constitutional cause, which is the commonest cause. All the girls of the family or of the community have early pubertal changes, and sometimes we have brain organic lesion, congenital like hamartomas and hydrocephalus, traumatic skull injuries, inflammatory like meningitis and encephalitis, where neoplastic, any brain tumor near the hypothalamus. For the other type of the complete precocious puberty, we have the peripheral or the false one, due to premature increase of estrogen, which is gonadotropin releasing hormone non-dependent. Many causes, including McQueen-Albright syndrome, precocious puberty, plus disseminated cystic bone abnormalities, cafe au lait skin patches, hyperfunction, endocrinopathies, hypothyroidism, which increases TSH with increased FSH, estrogen secreting ovarian or adrenal tumors, gonadotropin secreting tumors as choliocarcinoma or teratoma, and iatrogenic by giving exogenous estrogen. This will increase the level of estrogen, and so it is non-dependent on gonadotropin releasing hormone. For the incomplete one, mostly idiopathic, like premature thelarch, only the breast development passes prematurely and the other events are at the usual time, premature pubarch or axillarch, or both with each other, and premature menarche, which is the least event. If the prematurity is towards the heterosexual type, where male sex characters are developing, we have heterosexual precocious puberty. It is related to congenital adrenal hyperplasia, the late type. As you know, the early type will be presented early, and sometimes it ends into death of the neonate. Androgen secreting ovarian or adrenal tumors, increasing the androgen level, and iatrogenic exogenous androgens intake. How to diagnose a case of precocious puberty? Of course, we should depend on history, the timing of occurrence of pubertal changes, the sequence of events, what appears first and what next, and the type of sexual changes, either towards the male type or towards the female type. Family history of similar condition may point to the constitutional type. Symptoms of the cause like brain tumor, adrenal or ovarian tumor, and history of drug intake either towards the feminine or the masculine type. Examination, we should evaluate pubertal changes based on the Tanner classification, and signs of the cause sometimes could be detected. For investigations, we should do hormonal assay. We should find the level of FSH, LH, estrogen, progesterone, and androgens, and according to the finding, we can classify the condition. And also, we should do investigations to detect the cause, like doing CT on the abdomen and the pelvis. Sometimes we need to do CT for the brain. Sometimes we can evaluate other hormonal factors like TSH and prolactin, which may point for the cause. For the treatment, our aim is to prevent premature closure of epiphysis, which is related to the hormonal level. So we should apply psychological support for the girl and her family, reassurance and explanation of the facts, and try to explain the cause, treatment of the cause if there is treatable cause, and medical treatment to decrease gonadotropin secretion, giving the gonadotropin releasing hormone agonist, which is the best drug to treat precocious puberty, but this is limited by its cost and market side effects. Sometimes we give gestogen like medroxyprogesterone acetate, which will suppress the gonadotropin releasing hormone release, and the danazole, which has androgenic effect. Now for the delayed puberty. It is defined as absence of breast development, which is a secondary character, by the age of 14 years, or non-occurrence of menarche by the age of 16 years despite presence of good secondary sex characters. So we have two ages, either absence of secondary sex character and the absence of menarche till the age of 14, or occurrence of secondary sex changes but no menarche till the age of 16. The etiology, the commonest cause are ovarian failure, which is the primary type, Mullerian agenesis due to obstruction of the duct to the outside by any defect in the uterus, cervix, or the upper part of the vagina, and sometimes the condition is constitutional. We have three types. The hypogonadotrophic hypogonadism, where there is lower level of gonadotropins released from the pituitary, and by turn the gonads are subactive, which is sometimes constitutional. Hypothalamic causes of primary amenorrhea, resulting in reduction in the gonadotropin releasing hormone release or absence of its release, which by turn will affect the FSH and LH release from the pituitary. General causes of amenorrhea, pituitary cause of primary amenorrhea. The second type is hypergonadotropic hypogonadism, which include ovarian causes of primary amenorrhea. And the normogonadotropic delayed puberty, we have uterine causes of primary amenorrhea or outflow tract obstruction, or what's called cryptomenorrhea. So according to the gonadotropin level, we have three categories, and this is discussed in details in the lecture of amenorrhea. Remember, hypogonadotropic hypogonadism is called secondary hypogonadism, and this is secondary ovarian failure. Hypergonadotropic hypogonadism, this is primary hypogonadism, the primary ovarian failure, and the normogonadotropic delayed puberty, not true delayed puberty, but delayed menarche only. Actually, all changes occur, but the problem is in the outflow tract, and so there is no menarche. Diagnosis: deal with it as a case of primary amenorrhea, and this is discussed in the lecture of amenorrhea, and you should pass in the sequence of evaluation till you reach the diagnosis, and of course the treatment is also as in primary amenorrhea. Thank you.